Everybody see the pair of feet on the screen?
Yeah,
Apologies
we
if you
can.
don't like feet. Fantastic. Okay, so my name's Rebecca Elleray, and I've just started recently with the Healthcare Public Health team in the NHS Midlands. And I just want to welcome you to this session where we are just going to dip our toes really into several sources of population health data, look at how they may help us to understand aspects of health and care inequalities, and share with you a little bit of insight into the different benchmarking elements of the tools. So we do have loads to get through, and it may seem like a bit of a whistle-stop tour. So I apologise for that, but hopefully we'll take a bit away from this session. And I guess it's just a session really to say hello, we are here. And if you do want to know things in more depth, then we can start to think through what that offer is, and how we can perhaps do further sessions to help meet your developing intelligence needs. I just want to make sure and introduce my other presenting colleagues. So Bryn, would you like to introduce yourself?
Yeah, hi everyone. Bryn Shawnee, working within the improvement analytics team within NHS EI, leading on population health and right care.
Great, thank you. And is Chloe with us? Sorry, I can't.
Hello, yes, I'm here. Hi, so my name's Chloe Castellano, and I'm the relationship lead working in the model health system team. So that's supporting our internal and external users.
Now we've got David Pell as well.
Hello. Yep, I'm David Pell. I'm working as an analyst in the system improvement team in the Midlands.
And yeah, just say thank you to Alex Porter for organising this and getting us all in the same room. So before we go on then, what I want to do is just find out a bit about you in the audience and who you are. Hopefully you will, I can see a couple of you are ahead of the curve. That's great. So if you can all sign into menti.com and use that code and tell us where you're from, which ICB or organisation you're from and which area you're representing. That would be great. Got a few from Lincolnshire. Okay. Got a few areas represented, so that's good. A few CSU colleagues. Okay, so I think 16 is probably the number we're expecting. So I'll go on to my next question. Oh, we've got a few more. Okay, so I'll expect around 19 answers from now on then. Okay, that's great. Well, welcome everybody. So the next question then is, how would you describe your knowledge of model health system? Just want to get a bit of an idea of the level we're all at. Dabbled a bit. What's popular up to now? Okay, so we've got a fair few of us who have dabbled a little bit. We've got one who's used it a lot. So you can take the next session. And we've got a few of us who are completely unacquainted. So that's good. So hopefully we should all get a fair bit of understanding from this session then, and a need to know more. So the next question then, so I'm going to segment you all. Now I've not done this before, so we'll see if it works. But and I'm going to segment you by how you just answered the previous question, and ask you, how well do you know public health intelligence tools? Because you may have done a lot model health system, but not be as familiar with the public health tools. So that'd be nice to, is it working? I don't even know if this segmentation is working. Okay, so we've got a lot of people who've used fingertips. A few of us who have not really looked at them at all, so that's good. And a few that have used a wide range of the public health tools on a regular basis as well. Unfortunately, I didn't know how to use segmentation, but maybe I can figure that out afterwards. Right, okay, that's brilliant. So that's really good to know. And I think we'll crack on with the main session then. I think we've got good level of knowledge, but also people who learn quite a bit from it. So just a bit then about more of the detail around the specific goals of the session. So we want to enable you to start exploring the data at a strategic level and understand how your system might be different to peers in other areas. We'll give you an introduction or a reminder of the model health system from a population health and pathway focus. Then I'll show you through some of the public health data sources that can add further value to your data storytelling. And then we've got a bit of a case study from David demonstrating how he's brought together all this myriad of data to tell a story around respiratory health inequalities and outcomes. So next slide. So in order to just set the scene a little bit, I wanted to flash up this image from a training source around population health management, and that is available on the Learning for Health website. And when we circulate the slides, you'll get the link to this. And it's just to show, the different aims of population health management and make the point that we today are largely focusing on how we improve the health and well-being of the population and address health and care inequalities and how the data can help us understand this. But yeah, just to make the point that, there are other pieces of work going on in the regional teams around things like productivity and workforce as well. And another bit of setting the scene, I just really like flashing up this image. Maybe you've seen it before, but if you haven't, then it's nice to introduce it, as I think it's just really helps kind of hold in our minds why it is so important to understand the full length and breadth of the populations we serve and the points of the pathway that we need to measure our populations. And it just shows the reason why we need to bring together both population and patient data to ensure that we are really understanding what is driving the demand within our population, what their characteristics are. This can tell us around any unmet need that we are seeing within our populations and how that demand is being driven by the different patient groups who may be accessing and experiencing our services very differently, leading to different clinical outcomes for different groups, and also how this then is translating into some of those high level population outcomes such as premature mortality and healthy life expectancy. Again, I just wanted to share this resource with you as I think it just provides a nice systematic way in thinking through health inequalities and then how we map our data to help us understand or answer these questions. So things like, what are the main causes of death and poor health in my population? How does my area compare against national averages, targets, or over time? Is there evidence of inequalities within my area, either geographically or by subgroups? And we'll be showing you how some of the tools can help answer that specific question today. What are the main factors driving inequalities within my population? So things like, what are the wider determinants affecting my local populations? And is there evidence of inequalities within local and health care pathways? And you'll see that not all the tools are able to answer each of these questions, but when we bring them all together, it can help us to do that. So this is just a nice kind of representation of how some of the tools address each of these questions and the amount of relevant content that you will get in each of these tools to answer each of the questions. And I just think this is quite a nice way of mapping your data to your questions. So it might be something you'd think to do with some of your work areas, perhaps. Right, okay, so I think that is me, and that's where I hand over to Bryn and Chloe to talk through the model health system.
Thanks. I'll share my screen with some slides and then I'll do a live demo, all being well.
Fine.
Okay, have these slides come through? Great. Okay, so yeah, I'll just go into slideshow mode. So I won't be able to see any hands, but if there's any questions, if anyone wants to interrupt me, that's fine. But I'll try and leave some time for questions at the end as well later. So what is model health system? So for those that aren't already familiar, so this has expanded out from model hospital. As it says here, it's a free data-driven improvement tool. So we've got a range of data covering acute hospitals and more broad information now. So it also covers mental health, community and population-based metrics as well, obviously, hence the session today. I'll just skip through the rest of this as it's going to be covered in the rest of the slides and the demo. Similarly, this one I'll skip over. So this is the landing page. So yeah, this is at system level, so you can this can be viewed either as a provider level, system level and regional level will be coming soon, but at the moment the default is the system. So this is the landing page. So you can see there's 3 tabs up at the top for quadruple aim, productivity and clinical improvement, and then there's 4 sections or boxes within each of those. So different users may want to do different things, but you can see there's a population health box there within clinical improvement, and there's also, yeah, I'll come on to the quadruple aim sections later. So there's a few different places that you might consider to be a starting point. Some users will be looking for something specific and can dive straight in, but if you're looking for more of an overview, then the opportunities for improvement section might be a good starting point. So I'm logged in as Birmingham and Solihull ICB here, and yeah, what this page is doing is presenting some of the biggest opportunities across a range of different areas. So we've got day case rates, we've got length of stay, we've got theatre productivity. So yeah, range of different opportunities presented there. And then you can drill into any of those. So I've clicked on the length of stay for orthopedic surgery metric, which was showing there as the biggest opportunity of 19,000 bed days. So this page now provides an opportunity breakdown by condition within that specialty. See that tree map there. So fractured neck of femur is the largest box there. So that's a 7,000 bed day opportunity there. And then further down the page, you've got links which will take you to the specific metrics covered in that diagram. Okay, highlighted metrics is another way in. So what this is doing, this is pulling together all the metrics where a system is being shown as RAG rated. So ICN in the title there, that should be ICB, but performing worse. So generally these are set as the national median, but there are some that are set at a specific benchmark value based on relevant clinical levels. So yeah, you can then click onto any of these and it will take you through to view that indicator in more detail. And then there's also there's a view all highlighted metrics option, which just lists all the compartments and shows how many metrics are being flagged in each of those. So that's just a quick overview of two of the different ways in. You can also browse to look for any particular area, which is what this screen is showing. And then if you clicked on any of those, it would take you to those specific compartments. So this is now a screenshot from the population health compartment. So we've got a range of different subcompartments down the left-hand side, obviously loosely sort of based around the patient pathway. So grouping different types of metrics together. And then over on the right-hand side, we've got some of the headline metrics that have been selected, so some of the most important metrics. So within this page, they're typically based on admission rates per 100,000 population, or so bed day rates, but so some of those are non-elective and can be rag rated. Some of those where the non-elective isn't as important, such as cancer and tumours, just showing all bed days per 100,000 population. So just a little bit more on navigation. So yeah, you can click into any metric and you get a range of information, including the value, a link to the interactive chart, but also understanding the data source, and a detailed technical methodology section as well. And then this is the sort of main interactive chart. So this is the variation chart view, but there's also a time series view, and depending on metrics, you can view funnel plots or SPC charts. So this is the system level benchmarking, but if you look towards the top and the middle, there's a select level box, so you can change that to be CCG or provider, depending on the metric, what you can drill down to. And yeah, so what we've got here is the non-elective bed days per 100,000 population. So this is age, sex standardized bed days covering problems of circulation, so cardiovascular disease, including heart disease and stroke. So you can obviously see there that the higher rates are deemed to be worse. So those ICBs with higher rates are rated red. But you can see here that the highlighted system, Birmingham and Solihull, again is highlighted in black towards the top end. And then there's 5 peers who are highlighted grey. So these are the similar ICBs based on demographic factors such as deprivation, ethnicity, rurality, etc. So as is standard for this type of metric, deprivation is obviously a key factor affecting non-elective admissions and bed days. So the Birmingham and Solihull being one of the more deprived ICBs, and similarly its demographic peers are, then you can see there they're all clustered towards the top end. So yeah, in particular for some metrics, it's very important to not just look at the national distribution, but to compare to demographic peers as well. This is the subcompartment view. So yeah, if you click into any of those subcompartments that we're showing on the left-hand side, then you'll see a range of metrics. I've got the titles off here, but these are showing the values for the ICB, and then the national and peer medians, and then obviously the spine chart view over on the right-hand side.
So again, introduce, sorry, interrupted that second. We just had a good question about what population it is within these indicators.
Yeah, great, thanks, Alex. So the population, this is based on the registered population, not the resident population. So patients who are registered at a GP practice within the sub-ICBs that fall under Birmingham and Solihull ICB.
And in terms of the populations, at what time point are the populations for the data that you're looking at? So if it's in a quarter, do you use the population at the start of the quarter, end of the quarter, or the middle of the quarter?
So I believe that we run that every month and take the average, but I'm not 100% sure on that, so I can check on that. But yeah, it's yeah, I'll double check on that. Obviously, the populations don't vary a huge amount in a 3-month period anyway, but yeah, I will double check on that one. Okay, any other questions, or shall I crack on? Okay, so yeah, this is just sort of reiterating the point from the previous slide, really, in terms of importance looking at the demographic peers rather than just the whole national distribution. So Birmingham Solihull is RAG rated as red for each of these metrics. They've got higher rates of non-elective bed days per 100,000 standardised population. For each of those when compared with the national distribution. But again, obviously, deprivation being a key factor in terms of non-elective rates. So what we also include is an indented metric. So if you look at the arrow on toward the left of the title, then if you click onto that, then you view indented metrics that become unhidden. So we've got indented metrics here showing the potential opportunity from improving to the average of the demographic peers. So these are built up from sub-ICB level, where the sub-ICB is different to the ICB, which in this case it isn't. And so the opportunity shown here is if the system reduces its rate of non-elective bed days to the average of its 10 most similar demographic peers. That's at the sub-ICB level. So you can see there that for cancer and endocrine, nutritional and metabolic disorders, the ICB has got one of the highest rates in the country, but when comparing to its 10 most similar demographic peers, the average of those peers, then they don't have an opportunity there. Their rates aren't any higher, statistically significantly higher than the average of those peers. Whereas if you look at the neurological one, which is the third one down, then there is an opportunity there. So if they reduce their rates down to the average of the demographic peers, then that would save 7,000 bed days per year. Okay, I'll just pause there and go into the live demo. I'll just check first, though, before I go into the demo, whether anyone has any questions on the slides or anything they'd particularly like me to go over in more detail in the demo.
Stephen's asked some good questions about how we combine population catchment data, LSOA, registered population, ONS populations and stuff like that. So probably a deeper question for us to pick up at the end on that. So I'll let you crack on. Not seen any other questions.
Great. Okay, I will just reshare my screen then. Then I can laughing as well. So I'll just start. Actually, can I just check how long I've got left on my section before I dive into the demo?
Yeah, you're all right. You've got, I reckon, till about 10 to.
Great. Yeah, this is the landing page. So as I said, you can currently view at select organisations, provider level or ICB level. So yeah, just below your name in the right hand corner is the organisation type. So if you wanted to select an acute trust, then you could filter that and select one of those. However, I'll stay in the ICB view for now. So the landing page for this, as I say, there's these 3 tabs. There's the quadruple aim, a productivity tab, and the so yeah, it will just depend what you're most interested in. But for example, yeah, if you want to look at the quadruple aim view, then that's broken down into 4 sections. So better health, better care, better value, and staff experience and well-being, which is similar to the 5 areas Becca covered in the introduction, except we don't have inequalities here. That is going to be sort of just embedded across all of the sections. So for example, if I click into better health, then it will bring up a list of compartments that are most related to better health. So yeah, I've covered population health. There's also respiratory compartment, frailty, cancer, and pathway improvement program, which is a new piece of work in the last year, 18 months, that was focusing on eye care, cardiac, and musculoskeletal services. So I'd say, depending which of these, it will bring up the relevant highlighted metrics. And yeah, you can just click on the left-hand side into any of those compartments, and there's also some useful links underneath those. So for now, I'll just click into population health. And so this is the screenshot that I'd covered in the slides. So as I say, there's a range of key metrics, headline metrics that have been selected. So these are program level, so based on the program budgeting category view of bed days. As I say, largely speaking, we've selected non-electives and RAG rated those, but for some, for example, eye care, we've taken a different approach because the majority of the activity there is outpatient based. So we've just included the outpatient attendance as per 100,000 population instead. So I also showed the non-elective admission subcompartment. I'll just click into that again, so you've got a broader view of what's included in there. So we've got separate domains. I was focusing on bed days before, but we've also got admission rates, then we've got bed days, then we've got the spend or the tariff weighted activity. So that's, yeah, just bringing more of a case mix view into it in terms of applying that tariff cost to the admission. So again, I'll just show you how I navigated to the view that I included in the slides. So you can click on the one I'd chosen before was problems of circulation. So if you click into that, then it gives you the description of the metric. And yeah, there's a section on understanding the data, and as I say, data source and methodology. And then to view the interactive chart, you can just click onto that, and then that will bring up again the variation chart view that I included in the slides. You can drill down to CCG level, although for Birmingham and Solihull that doesn't add much, as it is just a single sub-ICB/CCG within the ICB. But where there are multiple CCGs or sub-ICBs, then they will all show up on the chart highlighted black. As I mentioned, you can also view time series. So on the top right hand side, if I change that from variation to trend line, then that will just show you a quarterly time series of that metric. So here we've got the ICB highlighted in blue. Then we've got the peers in grey and the system median in black. You can get rid of any of those if you want to by just clicking on them and then click to add them back in. So yeah, if for example you don't think that that's the national median there, that system median. If you don't think that's a useful view, then yeah, you can just take that off. One other thing I would highlight, I've got recommended peers selected, but you can view that within the region as well. So if you go into the top left-hand corner, you can change that to my region. At a provider level, there's a much wider range of peers that you can select as well, and you can make your own custom peers as well. So I think that's the main functionality. I'll just pause again to see if there's any questions it's worth me stage.
We've got a question about getting access to the source data behind this, which is quite an interesting one. So there's a download function that I'm sure Bryn can show us quickly how you can kind of download a whole section of data for your system, which is useful if you want the info. But to get behind this is source data that we've standardized. So if you've got any questions on that, that's where you can come to myself. I'm Alex, I'm kind of the analyst Cleveland region, or Beck or any of the team that's kind of will share contact details on. You can show where that comes from. And then there's some definitions I think we can see in terms of the codes usually used for these indicators below each one.
Yeah, that's great. Thank you. Yeah, so the codes are included in that methodology section that I showed earlier. In terms of download, yeah, so on the top right hand side of any chart, you can choose to download, and you can download the chart in that way, or if you switch from chart view to table view, then instead of showing a chart, it will show a table with the data, and then you can click the export button, and it gives you an option to download the file, which I won't do now, but yeah, hopefully that answers that question. And yeah, Alex has kindly offered to take any questions on the underlying data. As I say, we have included as much as sort of we think is useful to include, but yeah, very, very happy to sort of take questions that aren't answered by the metadata. And there is a well, Chloe will come on to it but yeah, there are sort of various ways to ask questions that get sent to the Model Health System help desk as well for people who do have questions. Alex, is there any others you think may be worth covering now?
I think that's it, unless someone wants to jump in.
Okay, well, I'll just quickly show some of the other information included within this compartment then. So risk factors within there, we've got smoking and obesity and alcohol consumption and other public health metrics. Prevalence and detection, we've got the QOF reported prevalence here. So yeah, range of disease as covered in that QOF data. And then we've got estimated prevalence, so coming generally as published by PHE, OHED now, and yeah, then where there is both estimated and reported prevalence, then we create metrics there to look at the ratio of those, or the detection rate as we'll call it. So for example, here for coronary heart disease, then for Birmingham and Solihull ICB, then just 59% of the people who are estimated to have coronary heart disease are actually captured on the GP registers in that QOF data. Again, all the same sort of functionality applies, but I won't repeat that. Just pick out some of the other data. We've got all of the QOF achievement metrics in there. So if broken down by program category, so for example, respiratory, we've got a range of metrics there, including measurement of COPD, percentage of patients who've had a flu immunization, etc. I've covered the inpatients, so we've also got primary care prescribing data in here. So the metrics are set up in a similar way. We've got both items prescribed and the net ingredient cost of those items. So again, age sex standardized per 100,000 population, and again broken down by program categories. The inpatients was done on the diagnosis codes. There's a mapping of the individual chemicals that go to each of these program categories. So yeah, just to make you aware of that information as well. I won't go through any others, but yeah, we've got referral to treatment, so a lot of information on waiting lists and waiting times, diagnostic waiting times, outpatient attendances, A&E, and also mortality rates.
That's a good point. We've had a couple of questions, really interesting one. One's on the estimated prevalence figures that we're basing on 2011 data. So to be able to describe where that's come from and if there's any chance of an update, which I'll let you explain that one. And then the other one's on the warning triangles, the red triangles at the front. Could you explain those on the front page?
Yes, sure. On the warning triangles on the
estimated on the browse section, I think.
On the browse section. Okay, yeah. So that's the those are the highlighted metrics that I showed earlier. So within cardiac pathways, then there's one metric where the system has been, or one key metric where the system has an opportunity to improve, and within cancer there are 4 metrics. In terms of the question about the estimated prevalence, yeah, so that's some of that is quite out of date. The estimates themselves, so it does say 2011. They have been up-rated since then, though. So the population that is being applied to that estimates is up-rated, but the actual prevalence estimates in terms of the percentage covered within that population haven't been. So yeah, so there's various models that are produced by different academic institutions, and yeah, so they're sort of models built up on things like smoking prevalence and yeah, other relevant things, and then breaking those down by different age groups to create those estimates. In terms of updates, it's a bit of a rolling program, but we are hoping to get a lot of those updated in the next few years. I think certainly within diabetes and the CVD, I think there's a lot of work underway to sort of update those models. Okay. Yeah, one final thing I just wanted to highlight was the inequalities metrics, as it's obviously, again, in the introduction. So what we've got in here, we've started, at the moment, we've just got this broken down by deprivation, but we're looking at other protected characteristics as well in due course. So we've got main metrics here, which are the absolute gradient of inequality, which is looking at the slope of the line of best fit if you're looking at deprivation plotted against the relevant metrics. So for example, in this case, primary hip replacements, so the rate of admissions, again, age, sex standardized. So I'll just click into the chart first, and then I'll give a bit more of a description of that. So it's a bit slow loading there, apologies, but yeah, so what you can see here is, again, so most of the ICBs in England actually have a negative gradient here. So what this is showing, so for Birmingham and Solihull, for example, that the most deprived LSOAs within the ICB actually have lower rates of elective admissions for hip replacements, as say, standardizing for the age and sex of the population. So for most conditions, you will see a positive gradient of inequality. So people might be familiar with the ambulatory care sensitive conditions metric, for example, where the most deprived, or patients from the most deprived wards, have much higher rates of hospital admissions for ambulatory care sensitive conditions. What we're seeing for hip replacements is the opposite. We also provide a breakdown by deprivation quintile. So you can see here for this ICB, that in the most deprived quintile, that's a rate of 43 hip replacements per 100,000 population, whereas in the fourth quintile, that's 91 hip replacements per 100,000 population. Again, as a reminder, that's age sex standardized. You notice that drops off in quintile 5 quite a large amount there, so that might be possibly down to patients going private, perhaps. So yeah, we've got those metrics for hip and knee replacements, and also for the total spend on admissions for osteoarthritis. And then, yeah, we don't have this in all areas yet, just some that were initially started with the Pathway Improvement Programme. But I'll just quickly show the one for urinary tract infections, because every single ICB in the country, and indeed every single CCG sub-ICB, has a positive gradient of inequality. So patients from the most deprived areas are having more admissions for urinary tract infections than patients from the less deprived areas. Okay, so I think I'll just hand over to Chloe now. I'll just reshare my slides to hand over to Chloe to talk about who contacting for further information and any questions. So Chloe.
Hiya, thank you, Bryn. Just wait for the slides to come up. So I have just shared the link at the top of the chat section. So it's model.nhs.uk. So do please go there to register and sign up if you haven't already done so. So hopefully we've provided a good account and inspired you to register. Is the slide coming up, Bryn?
Oh, well, it was for me. I will try to reshare.
So once you have registered and signed up, then you'll be able to access a range of our instructional support videos. So we do have an extensive webinar program, which we record all of our webinars and share them on the platform. So you can go to model.nhs.uk/videos, and there you'll be able to access everything. If you have any questions, specific questions about any of the data or metrics, then you can contact our help desk. So we have a team of people behind the scenes who are happy to answer your questions. So when the questions come in, they kind of get triaged to the relevant people. So you will be speaking to someone that should be able to help you. For those of you on Twitter, do give us a follow with our handle @ModelNHS. If you're working within a trust, then we do have a trust ambassador program. So we have over 200 model ambassadors now. So we aim to have 1 to 2 per trust. So when you're logged in, if you scroll down to the bottom of the page, then there'll be a little tile there that says contact your model ambassador. So they're expert users. So they're in continuous contact with us and the key point of contact within your trust. If there isn't any information about that person, then that means we do not have one for your trust. So we'd encourage you to get in touch. And if you think that's something you might be interested in, then we'd happily go through the ambassador program with you. And so if you could just go on to, oh, and so I did just want to mention, we do also have Future NHS. So that's a platform where we do share a lot of our support videos as well, and where we have there's like a forum there, so people ask each other questions, and also we provided extra support as well for you through Future NHS. And then on the next slide, please, Bryn. So this is just a bit about the webinar program. Thank you. So yeah, as I've mentioned, we have an extensive webinar program. We usually hold a couple, 2 to 3 webinars a month. We try and hold every month an introductory webinar as well. And then we do focus on sessions. So last week or the week before, we did a focus on data session. So it's a bit about kind of where the data comes from, what we do with it, and then how we push it out. So if that's something you might be interested in, we have recorded that. And we held our monthly masterclasses. We do lots of engagement with trusts. So yeah, please do have a look, and if there's something you're interested in, then feel free to register. So yeah, that's all for me. So back to Bryn, or handing over to Rebecca, I'm not sure which.
Yeah, I think I'll hand over to Rebecca and just try and answer any questions from the chat.
Fantastic. Thank you, Bryn and Chloe, for that. That was a really interesting part of the session. And yeah, well done doing it all the time as well. You covered a lot there. So I'm going to attempt to do just as good a job at timekeeping and do a bit of a whistle-stop tour through 4 different public health tools, which focus mainly on answering these types of questions circled in blue here. I'm not going to be able to give you a full demo of each tool, so I am just going to zone in on, I think, what are the unique selling points for these particular tools. So the first one is a segmentation tool, and it provides information on the causes of death and age groups that are driving inequalities in life expectancy, and helps us to kind of target the causes of death that are contributing most to this, the differences in life expectancy that we see. The link to the tool is here, and my colleagues over in the Local Knowledge and Intelligence Service also recorded a webinar back on the 16th, and I've put the link in there so you can go back and have a look at that. So yeah, just to say, I guess that the segmentation tool is really useful for answering those kind of high level questions around evidence for inequalities within our local populations and across subgroups, and understanding what the causes of death are that are driving those inequalities that we see. So I'm going to show you what the landing page looks like. Can everybody see that? Okay, so this is a landing page for the segment tool, and we want to go and have a look at the data. We click on this, and as you can see, there are various options and drop downs on the side here. We can look at a single time period, or we can look at trends. We can look at the most recent year. We can look at pre-COVID years. The geographies available are England, regional and local authority. I've chosen to look within the East Midlands and at Derby, and I want to make a within area comparison. So the scarf chart just gives a nice visual of the proportion of the gap in life expectancy between the most and least deprived populations within Derby, and which conditions make up that gap. So at the moment, we can also see the impact of COVID, but the biggest contributors to the gap in life expectancy are, I would say, circulatory cancer and respiratory disease. Sorry, just to say, there is a bit of a context page as well, which allows you to look at the kind of headline figures for your local authority. So compared to England, Derby has a gap in life expectancy of over 2 years for males and 1 year for females. But the gap between the most and the least deprived quintiles for males is 11 years and for females 8 years. And I think that's one of the biggest that we see at local authorities across the country. So as well as by cause of death, we can also look at the age groups that are contributing most to the life expectancy gap. And for females, we see that the majority of those are in women aged 60 to 79. But for men, we have a larger proportion of 40 to 59-year-olds contributing to that difference in life expectancy. We can also look at this data in a bit more detail. I'm going to look at this by cause of death. So this gives us the actual number of years that each of these conditions contributes to the difference in life expectancy. Where they are lighter blue, they actually offset the difference. So for women, there are fewer deaths than expected among deprived populations for cirrhosis and liver disease, other digestive systems, and suicide and injury. However, for the vast majority of conditions, they are contributing quite a number of years, and in particular, chronic lower respiratory diseases are contributing well over a year for females, and for men, heart disease contributes well over a year to the life expectancy gap. So just making those headlines really for where our efforts are best targeted. So I'm going to click through the screen grabs. So onto the next tool that I'll talk about is the Public Health Outcomes Framework. And many of you, particularly those working in local authorities, will have worked with this tool before. The link is there, and this is one of those fingertips profiles. There's lots of different indicators in here covering these 5 different domains. So the overarching indicators, which are all our life expectancy and healthy life expectancy ones, wider determinants, health improvement, health protection, and healthcare and premature mortality indicators. And the data is available at national, regional, upper tier and lower tier local authority data where it's available. And there are many different ways of showing the data. So there are area profiles, trends, tartan rug charts where you can see a number of different indicators for, say, all the areas within your region. There are also area comparisons, and you can also produce reports as well. But the main thing I want to focus on is the benchmarking functionality within the tool. So the tool uses what we call CIPFA, or I'll spell it out, the Chartered Institute of Public Finance and Accountancy, nearest neighbours. And these are areas that are grouped according to similarities based on lots of different population characteristics, such as age, deprivation, population density, unemployment, and a range of other kind of taxation and other kind of financial indicators. So this then allows us to compare our geography of interest to those of similar population characteristics, and perhaps help us to start unpick what may be driving the variation we see for our area. So what I'm going to do is navigate to the actual tool and give you a demo of that. So this is what a page from the FOF looks like. This is a landing page, gives you all the kind of information around updates and things. You press the start button. And so this is the area profile that you will see initially for your area of interest. And you can pick which domain you're interested in here to look at healthcare and premature mortality. As you can see, Stoke-on-Trent's doing particularly bad for a number of these. I'm going to look at trends, click on trends. I want to have a look at all in West Midlands for, and then I can pick my indicator from the list. I want to look at under 75's mortality rate. So yes, and then I can arrange these by latest value. Did that one. And as we can see, my area of interest, Stoke, has the highest latest value for under 75's mortality rate in the region. However, there are, a lot of different population or variation in the demographics across the region. So what I want to do is compare to similar areas, and I do that by clicking this box here. And there we can see all the areas that Stoke is comparable to, and the numbers here indicate the rank of that comparison. So Wolverhampton is most like Stoke in terms of its population characteristics. And here we can see that Stoke, compared to all its CIPFA nearest neighbours, has also the highest rate for the latest value as well. So there's particular drivers within the Stoke population that are of interest, perhaps, or under 75's mortality. So that's how you can compare to similar neighbours in FOF. Do now is go back to the presentation. And the third tool that I'm going to talk you through is local health. Again, here is the link to that. And there are 3 main functions of this tool, and I'll show you the mapping one and focusing on that. But I think one of the key things with this tool is that the data is available down to middle super output area, so we can start to see things in a lot of granularity. We can also build up bespoke reports based on grouping middle super output areas and other areas together. And we can also, there are 69 indicators available in the tool. However, you are able to upload your own data as well if you have all the ONS codes for it, and you know, map it and put it through the report functionality as well. So it's got a lot of flexibility, this tool. But yeah, one of the unique functions that I would like to show you is, and here's one I made earlier, I was a bit worried about keeping to time, is the to map function, where you're able to lay one map at the side of another and map two different indicators. So here I've done deaths from respiratory disease, and this is an indirectly standardized ratio, as is our small area indicators. And we can look at this at the side of the index of multiple deprivation score at MSOA level. So yeah, so it's really interesting to be able to show the variation across our region and be able to look at what demographics may be associated with that. So for, sorry, hopefully the dog's not going to start barking because someone's just come through the gate. So we can see that the indirectly standardized ratio of respiratory deaths from respiratory disease are much higher in some of these areas here where deprivation is also high. Move on now. So one of the tools I particularly wanted to show you was the SHAPE tool, or otherwise known as the Strategic Health Asset Planning and Evaluation tool. And there's a link to this tool there. And this supports the strategic planning of services and assets across a whole health economy by being able to map certain demographic and public and primary care data sets and be able to look at how those relate to things like where your hospitals are, where your GP practices are, and other kind of healthcare estates. And it also supports some travel time analysis as well. Let's go back to this. Okay, so again, because I was worried about time, one of the maps that I've produced looks at an ICB or a local authority area within Derby and Derbyshire ICB. There are different layers that you can put on the map, as you can see here. And the one that I chose was fuel poverty. And this gives us the shadings for the lower super output areas that we see on the maps. So the darker the shading, the higher the proportion of the population that suffer with fuel poverty within that LSOA. The red ones, if I just click across the interpretation bit here and choose the layer on that, you can see that those outlined with red are the highest 10% LSOAs for this indicator. And within Derby, we can see that, yeah, they're accounted for around a fifth to maybe 43% of the population classed as living in fuel poverty. So what I've been able to do with this map as well is map the QOF recorded prevalence of asthma. You can see here, these are all the different indicators that are also available to map. So I can show the QOF data by choosing the primary care category here. So this means I've now mapped my GPs where they are on the map, and the colour of those little tabs showing where the GP practices are tell us the prevalence of asthma within that GP practice. And the darker the purple, the higher the prevalence. Where you see the circles, this means there are 2 GP practices within that circle. or within that small area. And as you zoom in, you can start to see them separate out. But I just think it was quite a nice way of showing how we can start to layer these bits of information. So, for instance, we know that some of these areas where there are particularly high prevalence of asthma, we also have high fuel poverty, and that may suggest that we want to put some kind of intervention in with these GP practices to prevent any poor health outcomes for these individuals. So I think that's all I've planned to show in terms of the tools. How am I doing for time? Shall I take any questions? Are there any questions there?
I think Stephen's raised some interesting points. So if you want to come in, Stephen, about the challenges of when you have local authority data compared to NHS population data and provider data, and sometimes it's hard to tell the story and get the messages across. Do you have any?
It's probably not hard to tell the story. It's about the willingness to listen, isn't it? It's because essentially we may understand the differences, and I can live with the ambiguity of living with local authority populations and GP populations and catchment populations and trusts. But when you're talking about how to commission and transform a service, you've got to overlay all three of them to actually give a clear view of it. So if I'm looking at the over 65s and reducing admissions for Coventry as a place, that's Coventry as a place for a local authority means all the people who reside in Coventry, which includes lots of patients who actually are registered with practices outside Coventry, who are not actually part of the place discussions, but also from a provider point of view, the provider is actually a tertiary centre, and therefore actually 30% of it is, well, actually over half of its activity is for non-Coventry residents, and therefore the local authority has no interest in those non-Coventry residents. And how do you actually engage people and say, actually, this is something you need to worry about? And I think people like nice, simple graphs. So when they talk about Coventry, everyone comes with it with their own concept of what Coventry is, but actually they're talking about very different populations, and those populations vary differently. So if I use the registered population of Coventry is 420,000, the census population of Coventry is 345,000. There's almost £100,000 population difference between what the census is saying to what the GP registered population is. And if I then look at the residents of people in Coventry, I get to about 450,000 people living in Coventry. And it's how you actually explain that simply and actually overlay all of the metrics around it. Because when I'm using fingertips or using shape or whatever, you can be very clear about population, and it's understandable by one part of it, but then everyone else switches off because actually it's not their population. We haven't really integrated out the way that we, well, it would be a lot easier if actually all the populations were the same. So, yeah, GP registered population is really just a catchment population in the same way as the trust is a catchment population, but the local authority services is defined by population, and its catchment population is actually a geographic area. And that gives attention. I think ICSs are going to have to deal with that in very subtle ways, and need tools which actually are very clear and easy to understand. No answer there, it's just the problem.
Yeah, no, I totally agree, and it is a really difficult web to kind of unpick, really. I guess from my perspective, the stakeholders that I've often spoken to are interested in the residential populations and the kind of environmental and factors that may be driving the need for services, and and how we then go and carry out prevention and things like that within the resident population. So yeah, it's a difficult task, and I suppose one of the things that we always do when we think about pulling together a story is map out who our audience is and think about which tools might be best to get that point across to them.
We've got David next, who's going to try and tell us about storytelling and storyboards to try and help us sell the message of this data. So that's going to give us a bit of an insight into how that works. But Stephen, I just put on the chat a tool I saw in Foundry called the ICS Place Management Tool, which is kind of new. It hasn't got much data in it yet, but it does let you define your own kind of places and custom areas. So if you wanted to kind of say everybody within the kind of within a road boundary, allows you to create something as a place and kind of combine ICSs or GP data. So it looks really interesting, but I'm not sure that it quite solves your problem. But happy if
I think all people are struggling with this. So we're always trying to do that in terms of saying, actually, you need to be aware that there's 3 different types of populations in terms of the question being asked. In terms of things, what we can talk about is actually we can talk about differences in the age of death by local authority areas or by lower super output areas or MSAs or things. But actually the people that we're talking about there, when you're talking about GPs, if half of your population are not in Coventry, they're saying, actually, I want a service for the whole of my population. But actually the way we're defining things is it becomes a problem, because actually the local authority is the integrated systems, it still has an overlay of organisations within it, and people are not yet willing to break down those organisation boundaries. If the ICS was really Coventry and Warwickshire, and the local authority was Coventry and Warwickshire, and the NHS was Coventry and Warwickshire, and it didn't pay for patients who to be treated outside Coventry and Warwickshire, and didn't pay for patients who they have those patients who reside in Coventry and Warwickshire but are registered at GPs outside Coventry and Warwickshire. You've got all of those things overlaying on it, and there's some quite significant flows in this. So we've got some practices where 70% of their work takes place outside the ICB. And how do you engage with them in terms of getting them involved in work if it's only focused around an ICB view of the world and everything they're being told doesn't relate to them? So they'll see the shape, they'll see the things, and they say, well, actually, I'm an exception to that. And being an island ICB, we don't have a coast to define us, we've got lots of those people with flows on the outside where the practices have significant flows to other parts of the system. Again, no answer. It's just it's one of the things we have to struggle with. But I think it's a modern version of the questions we used to get with the right care and model health, isn't it? So the opportunities for providers is one. So there's a great opportunity for providers to reduce their need to follow-up ratios. You look at the population level of a commissioner, there's not a problem, because right care says your problem is something else, which is quite true, and both of them are true. But actually, it then prevents you from doing anything because it's not the priority of the other organisation you're talking to.
No, it's a conundrum. One of the things that I think you alluded to in your question in the chat was around trust catchment populations. Was that right?
Yeah,
Did you ask about that? So I'm just about to put a link into a dashboard. Sorry. That OHID have produced that just tries a bit of a methodology to look at and provide those kind of NHS hospital trust catchment populations based on what's happening with elective and emergency admissions.
Yeah, but the difficulty I have is I can come up with methodologies, so using the proportion of activity to actually infer the level of activity, that the level of the population that might be within an LSOA. That's not a problem, but then it needs to be done by specialty, because actually trusts have a different catchment population for each specialty. So if you're a tertiary centre, your tertiary services will have a totally different catchment population from your general acute services. And again, it gets very confusing very quickly when you start explaining to people that actually I'm using a different population denominator and they want to know why.
I think it, yeah, definitely a great point, and something that I think we need to take away and think about. So, David, shall I hand over to you and you can talk us through your case study in respiratory disease?
Last point I'll say about populations.
No, go on.
The biggest problem, of course, is ethnicity, in terms of nobody really has a clear view in terms of what the ethnic prevalence is within their local population. What they have is the census population of 2011, which has been amended and things. They've got a presentation population, which actually tells you what the ethnicity is. We've got GP recorded presentation, but actually 20% of those patients within GP systems don't have any ethnicity recorded, which means that anything you produce on an ethnic analysis from an analyst, we're saying actually the confidence limits are quite large. But people don't like confidence limits either, do they? They want the simple message.
Very true. David, are you going to cover the people and population insights tool? So
the happy one. Yeah, briefly, but yeah, I'm gonna show that.
That might show a bit of how that captures some of that information.
I don't think any of it answers your problem, Stephen. I think it, it just exists. And as you say, if we don't have ethnicity data, then you're sort of making guesses about that. Other comments about one of your earlier comments about where the patient died, or sort of looking over their life and where they were registered, and whether there was any analysis about that.
Yeah, it's one of my bête noirs when I talk about things, saying actually what are the things that influence life. We know that the evidence says good education at an early age improves life chances and all the rest of it. But I then use the example myself. So I'm 62 years old, but I was born in Lancashire in a very deprived area. I grew up in a deprived area, moved to another deprived area. I now live in the lovely suburbs of South Warwickshire in a very non-deprived area. What's going to have most impact on my life? Is it where I lived previously when I was a child, or is it going to be where I live now? And it's obviously a combination of both. But actually, most of the analysis we do is where people die. And people die in a place because of circumstances. So if you have chronic health conditions, you can't work, you end up living in a deprived area, and you die in a deprived area. Deprivation wasn't the cause of your chronic condition, necessarily. Yeah, it could be, but it could be related to where you lived as a child or where you worked when you first worked. And we need more of that analysis to actually be able to track patients through time. And if you look at populations of Coventry and Warwickshire, we have 5 to 10% of the population change every year. So it's not a static thing. And my fear is that population health management, we focus on helping people in a deprived area to move out, to have better life chances. They move out to the deprived area, people move into it with the same conditions, and therefore the indicator doesn't change. Yeah. And we're not able to monitor what the effectiveness of the interventions we've done has actually had on the people that we actually helped.
Yeah, well, I think it's difficult, and the IMD, Index Multiple Deprivation, is based on the location, and so it's things like access to healthcare, and so that's the place-based metric. I had a colleague who looked at social mobility, changes in social class over the life course, and the impact on health and everything. But in short, it just gets very complicated because, you know, I spent 10 years in IMD decile 2, and then 6 years when I went to university and I was in decile 1, but then I, you know, graduated and got a job and earned more money and etc. and then changed. Yeah, I think it's just becomes very difficult.
It is, and this is where there may be an opportunity for AI to assist in terms of this, in terms of being able to analyze data of the things. But when people think of linking data, I think they need to be also think in terms of we need access to data over a lifetime, which actually may be there in the GP record, but most of the time, most of our systems only record or retain where the patient currently lives. It doesn't actually say where they lived previously. And I think if we're really serious about population health management, we need to see how people got to where they are. And you know, most of the interventions we've got is how to prevent somebody who's been found to have a morbidity gaining more morbidities, rather than preventing them getting the first morbidity in the first place. Because until they come in contact with the health service, we don't know.
Yeah, absolutely. Okay, I'll crack on with my presentation. Rebecca, could you tell me how long I've got, please?
20 minutes, half an hour, till about 10 to, and we've covered quite a lot of the questions throughout, so I think 10 minutes at the end will do us to wrap up.
Okay, cool. I'll try and figure out how to share my screen. Okay. Can you see that? Anybody see that? And then big. Okay, cool. Yeah, so my part of this presentation is to sort of talk about how to put that all together and produce a story. So I've taken Rebecca's diagram there, the public health one, and sort of split it out into its components. I've also got some boxes, some categories from an actual piece of work that I did, looking at respiratory conditions in Birmingham, BSOL. And so I'm going to sort of talk through them. And I think it kind of depends what the question is, either it's a specific one, look at a specific condition in a specific system, or more of a general one. These are types of requests that I get. More of a general, give us a state of play, or what are our problems to look at. But I think either way, at least for me, it helps to sort of plan out the pathway and then create those categories, and then you can start filling in or searching for data sources and then filling in those gaps to try and tell a story. And so so the boxes along the bottom are things like wider determinants. So what causes the condition, incidence and prevalence, how many people have the condition, how can we stop people having the condition, what can we do to manage the condition, what impact does it have, and then ultimately what happens to the people in the system in general with that condition. And so, you know, do they die, do they get better, can they just live with the condition and it's not very burdensome. And so for my case, I produced a summary at the start of the pack, which sort of tried to answer those areas. So you can just sort of present this and go, okay, so in BSOL, it's the most deprived ICS in the country. Lots of fuel poverty, smokers, and patients who are classified as obese, as sort of average. And there are some areas of poor air quality, perhaps underdiagnosis of COPD, variation in cough measures, but they're not necessarily related to deprivation in ethnically diverse areas. In terms of prevention, there's perhaps more flu vaccines could be given to try and stop people getting flu, to stop people getting ill. And then looking at condition management, average number of exacerbations of respiratory conditions, low numbers of COPD patients offered pulmonary rehabilitation, some treatment to try and manage the COPD, and then looking at the hospital side, large opportunity to reduce non-elective respiratory bed days, some opportunities, and then looking at mortality data as well. There's limited amount of mortality data, but it depends on the outcome you're looking at. Just a sort of note that I have in general about how to make slide packs. I quite like the use of icons and sort of themes and making them throughout. And there's lots of places where you can just get free icons. You can either create an account or you can just cite the icons. But yeah, something like free icons. And I just did that. And you can just whip out hospitals and stick them in your slides, which is really good. So I like to present the context, and so you can know who your peers are, know who you're sort of positioning yourself against, and so these are the peers for BSOL, Black Country, other sort of industrial centres in the north, Nottingham, Manchester, Leeds, Sheffield, and then again sort of baseline characteristics, like okay, so that's what we're comparing to. What's that population look like? What's the demographics? And so yes. So BSOL covers Birmingham and Solihull, which are kind of different. Birmingham's a big city with lots of people. Solihull's not so big. Solihull residents tend to be older. They tend to be living less deprived areas, and also less ethnically diverse. And these slides come from the PAPI dashboard, which hopefully I can just tab to that one. No, I don't think you can see that. Okay. Let me just switch screens. Just the wrong one. Yes, can you see that? Hopefully you can see that. Can anybody tell me? I can't see the chat. Sorry, thank you. I can't see the chat. Okay, cool. Yeah, so this is the PAPI dashboard. I think it's just reloading because I've just clicked on it. Hopefully it's not doing anything too crazy. Which stands for Population and Person Insight Dashboard. Just reloaded in time to give me that. So it allows you to break down by various regions, SDPs, CTG, PCNs, age groups, gender, ethnicity, and index of multiple deprivation quintiles, and produces segmentation characteristics. So this is telling me the population, the percentage of the population were healthy well, and then if I select a random CCG, I think that was Devon, it'll do things like tell me how well Devon compares to England. So in, is that what I said? Dorset STP. So 3.4% of the population are lower than in England. So I think England was 72%. So yeah, so there's fewer healthy well people, more long-term conditions, disability, incurable cancer, organ failure, frailty, and dementia. And then these slides, these images look at total population. So the black line indicates the England average, and these bars, there's a gap there. So there's fewer people there and there's more people there. So generally older. Again, black line indicates England. So there's a greater percentage of people in the white ethnic category, fewer people in the Asian ethnic category, less deprivation. Other things like number of conditions, spend per conditions, and lots of good metrics to look at. And take a second, so it's not great for just zooming through, but you can see at the top there, prevalence, utilization, and exposure, I think. Risk of multiple long-term conditions difference, geography, Pareto, health span, etc. Stick that in the chat. And then back to my slides. Hopefully you can still see that. Okay, cool. Yeah, the links are there. Don't know. Maybe somebody else could do that because it's a bit tricky to do what I'm doing. Further things, again, the IMD values, and so you can see that in BSOL there's a much greater proportion of people living in IMD decile number 1 and a greater ethnic mix. And
Sorry,
then
can you go to full screen, David, again, please? Because it's showing you the notes bit. Sorry to interrupt.
Thank you. Okay, there we go. Yeah, and then just benchmarking that against other systems. So yeah, so Birmingham is the most deprived ICB in the country. Then this is a chart that I created looking at the PCNs and how they rank, and so the lighter shading indicates a greater proportion of people in the lower IMD deciles. And that was done using mainly SUS data, and then there's access to healthy assets, which it's got some cool metrics in there as well about looking at neighborhood determinants. And then same sort of thing, PCNs by ethnic group, and then the lighter color here indicates the white ethnic group, and so just sort of indicating, again, background measures about this is our area, this is our system, and this is the ethnic breakdown we have. So it's providing context of when you then go on to benchmark and show the position relative to other trusts or systems, that here are some factors that can explain the differences. So again, fuel poverty, another wider determinant of respiratory conditions and poor health in general, physical inactivity, smokers, and then this image is from the Global Burden of Disease tool, which provides an evidence base for the things you've chosen, which is quite nice. It's not an exhaustive list, but it sort of says, okay, here's some evidence that smoking is actually bad and linked to COPD risk. So it can help sort of emphasize the point that smoking is a bad thing, or whichever condition you've chosen. And then air quality maps. These are for various different metrics. Sulfur dioxide, particulate matter, 10 nanometers, nitrogen dioxide, if I remember correctly. Taken from the shape tool, which can sort of indicate areas of poor air quality, which are related to respiratory conditions. So again, just sort of background measures. And then just a little trick that I use. You can sort of select. There is a tool to select backgrounds to format pictures in PowerPoint. Just got a picture format, background removal, and that's just a cool way of emphasizing your images and playing around with your images that I use quite a bit. Then looking at reported to estimated prevalence to sort of go, okay, so we've got moving on to, we've talked about the population in terms of wider determinants. Now looking at how many people in the population have respiratory conditions. And so the reported to estimated prevalence is quite low, which suggests that potentially there's a gap there. And so maybe there's an opportunity to find those people. Percentage of patients with COPD who have an influenza immunization, is not a massive difference, but again, some opportunity there. and then these are QOF metrics, but taken from model health system, showing COPD patients with a review. So again, sort of trying to create that story of here's my population, and then looking at the conditions that they have and areas of opportunities that could be exploited. Further metrics from QOF about COPD, and I'm not going to attempt dysnopia. Yeah, I'm not a clinician. Problems with the respiratory condition. Problems of the respiratory system, and there's a large opportunity there for BSOL in terms of non-elective bed days per 100,000 population. And again, influenza pneumonia, non-elective bed days. And then this chart sort of looking at admissions due to pneumonia to sort of show back to an earlier point about whether these things are temporally related or due to COVID or something. And so plotting the time series shows that it's been getting worse from 2008. And then you can see the big drop there, but it's sort of spiking up again. And then breaking that down by across the time series by IMD quintiles, and you can see that IMD deciles, the greatest proportion, sort of always around 30+% of patients admitted due to pneumonia are in IMD decile 1, which is probably as expected given the background population. But then we can sort of go, does that differ? Is it as expected? We know that 35% of the population are in IMD decile 1. So are we seeing a greater percentage, or perhaps fewer people than would be expected? It looks kind of like that, like it sort of matches up. And then by pneumonia admissions by ethnicity, and the big chunk there is white British. This was sort of more exploratory to see, looking at whether there were patterns, but perhaps you could collapse those into fewer categories to give more of a clear picture. And then trying to sort of split out, okay, so there are lots of admissions. What sort of people are they? Are they older people? Are they care home residents? Are they the frail people? And so is this as expected, or are they a sort of more of a healthy population where you perhaps wouldn't expect so much pneumonia? So yeah, so here I've split it by care home residents and then age groups, and kind of as expected, the majority come from older age groups. And then this is just some cost data around that, trying to moving on to the acute demand, and so looking at cost data around that, and bed days and potential opportunities there. And then the final section looking at outcomes. So there isn't a lot of mortality data available, but the percentage of respiratory disease deaths in usual place residents is low, which perhaps suggests that people are more likely to die in hospital, which maybe isn't the best place to die. And then respiratory disease mortality rate per 100,000 population, again, another metric where there's an opportunity in BSOL. This data is from the Global Burdens of Disease tool, again, looking at asthma now, and it's, again, there's the sort of problem of the population we're talking about, and so this tool splits it by local authorities, so looking at Solihull and then Birmingham, but it's quite nice that it presents percentage deaths and then the absolute number of deaths. and we can see that generally there's been a drop over time for asthma deaths, but that COPD deaths are increasing slightly in both Solihull and Birmingham. Some other useful resources, we've talked about model health system, the right care tools available, and then also the other data set that I mentioned. Okay, and I think that's me. Is anybody any questions on that?
Don't think I can see any in chat. No, thanks for that, David. Really interesting story that you've been able to tell there with all those different bits of data. I don't know whether yourself or Alex could give any insight into how that's landed with BSOL and what have they done with it? Oh,
Yeah,
that's another good question as well. Sorry, Alex has just asked another good question.
Sure. How long does it take to put a story together? I think it can depend. It can depend on the complexity of the question and what you're looking at. Maybe a couple of days to find the data sources, depending on if you're just grabbing stuff from Model Health System, great tool, and it's often all there. Then obviously that simplifies my job dramatically. But if there's bespoke analysis, then that can obviously take a bit more time. Finding data sources, extracting, producing plots, etc. And then your question, sorry, Rebecca.
Just about how the piece of work has landed with BSOL and what they've gone on to do with it.
Yeah, yeah, I think it's helpful, and I feel like a good piece of work just gives me more questions, and it's sort of like, okay, this is interesting. Can we look further? And it's often difficult to sort of gauge the level. We could just go on forever and produce 250 slides, but then I suppose the art is pulling out the meaningful metrics and then allowing you to see at a relatively straightforward level what's going on. And then yes, when I do get questions back about, there's an opportunity there, could we look in further detail? I feel like that's a positive outcome, and where the real dialogue is, and then you can get to sort of specific questions and potentially identify good areas of opportunity that can be dealt with, looked at. Question: when I pull the data from the various sources, do you encounter difficulties in the data presented at different geographical levels? Yeah. As we've talked about earlier, and Stephen's highlighted, there isn't really an answer. I think what I tend to do is just sort of paint the picture and kind of go, well, these data are at BSOL, these data are at local authority, and they're sort of showing the same thing. Yeah, I absolutely take the point that they're not the same population, and then we can sort of look at that further and go into greater depth, and sort of that image that I showed earlier, and that me and Becca shared, the acute catchment tool, for example, shows the population flows, and using HES data or SUS data, you can look at where the patient resided and sort of map them into greater depth. But yeah, it is what it is, and it's about trying to start the conversation, sort of go, there's this general agreement, or this is an area we can look into it further. Okay, Alex has got questions.
I've just got some prompts for the other people on the call, but I guess it's one of the things is just not getting stuck on perhaps the DSO. I know it's really important for some services, and I guess Stephen's point entirely in terms of where it's got challenges, but I think some of the questions are, where do we prioritise resources this year, or where do we want to focus? And I think perhaps sometimes when we're looking at the bigger pictures, perhaps we don't need the precise data. I don't know. Just interested where others go with this sort of data. If you have that kind of chance, or any kind of gaps, actually, where do you think you need to add more to this kind of? Where do you think we're not covering? If something else you need? Should we go on to the final bit, Becca? Perhaps people can kind of type any questions in, because we've got a bit of a prompt, haven't we?
I have, yeah. So I'll share my screen again because we're going back to Menti. So hopefully it works. So what if you can see it on your screen, what 3 things would you like to know more about? And that could be a tool, it could be a theme, it could be a methodological question. I think there is some food for thought from what Stephen was saying around the way that we measure our populations and how that fits with the right audience. I think there is an interesting piece of work perhaps around that to do. But please, if you want to start adding anything else that you would like to know more about in Menti. Is everyone's Menti still working?
Just had to log back in, but it's still there.
Okay.
3 boxes. You have to think quite hard with 3 boxes.
Yeah. Or even just one thing. What's your top thing you'd like to know more about? While we're perhaps thinking about that, there's another question from Chen Yu. So what are the data sources for the data pack that David pulled together? She noticed MHS, the PAPI, the AHAH, and the Global Burden of Disease tool, and the Power BI segmentation tool. Did she miss any, David?
Yeah, there's quite a few. I think most of them are available. I think some of the bespoke analysis can sort of depend, and I think maybe I have different permissions, but yeah, I can when we share the slides, they'll be in there. I can put them in the chat now as well. I'll just do that. That's fine. Obviously we've got MHS, and I'll just go and paste some links.
There were some things we didn't cover on this call. I know on the Model Health system, there's some data that follows the Right Care Focus Pack areas. So if you're interested in, say, respiratory, you can go into the respiratory compartment. There's a lot more detail on a procedure level, the diagnosis level, and other details. So if people do want to go into more detail on a program, there's a whole kind of range of extra detail we can put on there. We've got some new primary care network packs coming up. So Bryn's team have been producing some benchmarking that goes below CCG level and goes down to the primary care network level, compares to similar systems. So we're trying to signpost that to all people as we go forward. We are trying to look at more data at local level and how we go up from LSOA, MSOA, and make that kind of comparable to what you might see in the Model Health system. I'm not quite sure how we do that and make it reliable and robust, but I'll go and pick out a few of you. Stephen, you might get a call. I'm interested in your thoughts on that. I agree with what's coming through the chat on ethnic categories, data quality. On the single point of access, I think this is something I really like people's thoughts on is, how do we, as a region that probably see a range of these data sets, how do we give you a good list of what's available? Something David, Becca and I have been working on is, do we kind of put some regional website in front of this, some kind of portal that says, actually, yeah, go to this and here's where the data is, or just have a Google document we thought about having where we share links to this. We'll share it out after this kind of call to everybody who's on there, but if you think that's useful, well, thumbs up, thank you. But yeah, if that's helpful, it's tricky to know how we get through to people because there's only so many newsletters you can read and webinars you can go to and future sites you can visit. So I just wonder what is going to give people the best tool, and most because actually I think it gives people the opportunity to share knowledge across the ICBs. Is there some way you want to go to share your knowledge if you find tools and resources that help you? because you guys have got much more experience of doing your work than us. So all thoughts welcome in terms of that collaboration. Yeah, founders are paying with some of that stuff. I wish more stuff could be in the public domain, Stephen. That would be a goal. Okay, we'll focus on the a few people asking for kind of an open portal for pointing to stuff. That's helpful, thank you. Who was UEC bundle metrics by POP? Somebody explain what a UEC bundle is, because that's not a term I'm familiar with.
That was me, Alex. It's Nathan here from BSOL ICB. Those are the clinically led review metrics that I think came out a couple of years ago in kind of shadow form. So I think it's things like, average time in department and some of the kind of clinically ready to proceed time. So I guess it's just how ED departments are working for different populations and how that might vary across geographies.
Interesting. I don't know if Bryn's still on. If there's any work he's doing nationally on that, if he wants to come in and say anything.
Yeah, I am still on. So there's a couple of dashboards that are in the A to Z applications that was shared earlier. So I think there's the SEDIT dashboard. I'm not sure if it covers that, but they have information. It's in the process of being updated, so I think a new version will be out in the next, well, not sure about Christmas, but a couple of weeks or so. And so that's the Summary Emergency Department Indicator Table, I think SEDIT stands for. And then there's the SAMIT, which has a similar scope, which covers ambulance as well. And yeah, in terms of work we're doing, we are doing some A&E based metrics, starting off with just an extension of the rate per 100k population metrics that we've got in there at the moment, breaking down by the SNOMED diagnosis codes and the chief complaint codes. But we're also going to expand that a bit further in due course and look at things like frequent attenders, so more than 10 or 15 admissions per year. But yeah, I haven't come across the bundle metrics myself either, but we can definitely look into those.
Excellent. I think we're losing people, Becca.
Yeah. No worries. Right, fantastic. Well, thank you all for your time, everybody. Hopefully you've all taken away some useful messages from that and information, and we'll be in contact soon with some of the things that we've taken away to think about, won't we, Alex?
Thank you for your time. Thanks for the questions, and yeah, it's been a useful session.
Right. Thank you.
Thank you. Bye-bye.
Bye.
Thank you very much. Bye.